Here is a detailed comparison of familial hypercholesterolemia FH and lipoprotein lipase LPL deficiency, elaborated on 15 major points. Down 1. Definition. Familial hypercholesterolemia FH is an inherited condition characterized by extremely high levels of low-density lipoprotein cholesterol, LDLC, often referred to as bad cholesterol. It leads to premature cardiovascular disease. Lipoprotein lipase, LPL, deficiency is a rare autosomal recessive metabolic disorder where the enzyme LPL is either absent or non-functional, resulting in the inability to break down triglyceride-rich lipoproteins, causing massive triglyceride elevation. Primary lipid abnormality. FH primarily causes elevation of LDL cholesterol. LPL deficiency leads to accumulation of triglycerides due to defective hydrolysis of chylomicrons and VLDL. 3. Cause, etiology. FH is caused by mutations in one of the following genes: LDLR, low-density lipoprotein receptor, APA, apolipoprotein B, PCSK9, proprotein convertase subtilisin kexin type 9. These mutations impair LDL clearance from the blood. LPL deficiency is caused by mutations in the LPL gene, leading to absent or dysfunctional lipoprotein lipase enzyme. This enzyme normally breaks down triglycerides from chylomicrons and VLDL into free fatty acids. And 4. Mode of inheritance. FH is autosomal dominant. One mutated allele is enough to cause the disease. Heterozygous FH, 1 in 250 people. Homozygous FH, very rare, 1 in a million. LPL deficiency is autosomal recessive. 2 defective alleles are required, 1 from each parent. 5. Age of onset. FH can present in childhood in the homozygous form, but symptoms usually become apparent in adolescence or early adulthood in heterozygous individuals. LPL deficiency typically presents in infancy or early childhood with symptoms like abdominal pain, pancreatitis, or eruptive xanthomas. 6. Serum cholesterol levels. FH total cholesterol levels are markedly elevated, often over 300 mg per deciliter in heterozygotes and above 600 mg in homozygotes. LPL deficiency. Total cholesterol is often normal or mildly elevated because the main problem lies with triglycerides, not cholesterol. 7. Serum triglyceride levels. FH triglyceride levels are usually normal or mildly elevated. LPL deficiency. Triglycerides can reach extremely high levels, often exceeding 2,000 to 10,000 mg per deciliter, especially after fat intake. Physical manifestations. FH, tendon xanthomas, especially in Achilles tendon, xanthelasmas, fat deposits on eyelids, corneal arcus, cholesterol ring around the cornea, LPL deficiency, eruptive xanthomas, small, yellow papules on the skin, especially buttocks and elbows, lipemia retinalis, milky appearance of retinal blood vessels, hepatosplenomegaly, enlarged liver and spleen. 9. Risk of pancreatitis. FH, pancreatitis is rare. LPL deficiency, high risk of acute pancreatitis due to very high circulating triglycerides, often precipitated by fatty meals. 10. Cardiovascular risk. FH, very high risk for premature coronary artery disease, myocardial infarction, and stroke. LPL deficiency, despite high triglycerides, low to moderate cardiovascular risk. Atherosclerosis is less common. 9/11. Response to diet. FH, dietary changes, low saturated fat and cholesterol help, but pharmacological intervention is usually needed. LPL deficiency, diet is crucial. Patients must follow an extremely low-fat diet, usually 15% of total calories from fat, as fat intake directly raises triglycerides. 12. Diagnostic lipid pattern. FH, isolated elevation of LDLC with normal or borderline triglycerides. LPL deficiency, chylomicronemia with elevated triglycerides and a milky plasma appearance. Genetic testing. FH, mutations can be detected via genetic testing for LDLR or PCSK9. LPL deficiency, confirmed by sequencing the LPL gene. Other genes, e.g. APO2, GPIHB1, may also be involved in rare variants. 14. Treatment options. FH, first line, statins to lower LDLC. Others, ezetimibe, bile acid sequestrants, PCSK9 inhibitors. In severe cases, LDL apheresis or liver transplantation. LPL deficiency, strict low-fat diet, medium-chain triglycerides, MCTs, which bypass LPL metabolism. Gene therapy, e.g. alipogene tiparvovec, is approved in some countries. Fibrates and fish oils are often ineffective due to the absence of LPL. Hasher 15, prognosis. FH, without treatment, high risk of early heart disease. With treatment, life expectancy can be normalized. LPL deficiency. Prognosis is generally good if dietary control is maintained. However, pancreatitis can be life-threatening if unmanaged. Thank you. Have a nice day.